Yeah, thank you. And also warm welcome from my side. I will try to share you some insights that we gained with the cPET tool at LMU Hospital. In principle, I think most of you will be aware on what we have now understood in Alzheimer's pathophysiology. In principle, and this is are the check curves that are present all over the globe now for all these biomarkers that we know for Alzheimer's disease. And as you can clearly see, that was first kicks in is beta amyloid that you can measure with PET or CSF. So that appears years before you experience clinical symptoms like mild cognitive impairment or dementia. So after the amyloid, you have then tau and then also changes of neurodegeneration. But this shows us that in principle, the amyloid and amyloid PET is a very elegant tool to get to an early diagnosis in the biomarker course of the disease. We have also asked the question to our own data, so how to assess best now the amyloid status of individual patients. And I think this is a very relevant slide because it shows you that it's in principle not a clear answer to only one of the tools that are available. So what we propose is a joint algorithm of CSF and or blood markers that will appear soon, and then also PET imaging. And why this is important? So if you look at the data that we have here in-house with A-beta CSF and also confirmed by an independent data set of the Medical University of Vienna. So if you have an A-beta ratio above 7.1, you will find only few cases that are amyloid positive. So here, in principle, your CSF test is already rather good. And the same holds true if you really have cases that have a very low A-beta ratio below 5.5. So here you see 90% or 86% of amyloid positive cases in PET and only few cases with a negative amyloid PET. But where you really have a coin flip in the end is in this intermediate range. And this is for our data, it was a ratio between 5.5 and 7.1. So also across data sets, this is very similar. And in this scenario, an amyloid PET is around 50% positive. So in principle, this clearly shows you that the amyloid PET as a follow-up test has a very strong additional value in these cases. So in our own cohort, we have scanned more than 500 cases now with amyloid PET, and we have used flutemetamol and florbetaben in all these individuals, and we analyzed the centiloids with cPET. Not for all directly at the scan, so also some cases retrospectively, but for those we have the centiloid values, and we have also the A-beta ratio. And what you can also see, what emerges now in university hospitals is tau PET that we even gained in now 42% of the cases. But starting with CSF and the cPET centiloids. So I think this is a plot that you can find in a lot of papers and that you can also find now in a lot of real-world settings as ours. You can see that there is a proportion of cases that have rather clear positive centiloid values, so above 50, and that are then also clearly separated from individuals with clearly negative centiloid values. And you can also see that the CSF values are separating these populations in a similar way, but that there is still these overlapping regions. And this accounts for both. This accounts for the CSF. So if you look here at this 5.5 to 7.1 borderline region, and also if you look at the centiloid values here in this intermediate range, there are still a lot of cases where you get not a clear result, so not a clear positive amyloid PET, and also not a clear negative amyloid PET. And I think here the quantification is of course very interesting and has also large additive value. how good is this quantitative readout compared to what is an established visual read? Yeah, I think in our center, this is also real world data, so completely unbiased, just the reports that were generated over the last 10 years. And this in comparison against then a centiloid quantification with a data-driven cutoff of 35, which is, I think, very, very congruent with that what was published by the MPET consortium. And you can see that there is nearly a perfect agreement between quantification and this long-term established reading. So to understand that, in our department, every resident is undergoing the trainings for florbetaben and flutemetamol, and the report is then first written by the resident and also afterwards then validated by a second physician that has experience of more than 300 amyloid PET reads. So you can see that this is really then I think this can act as a gold standard, and you can really see that the quantification is also nicely providing you the same accuracy. And you can see that it is also relevant to do the amyloid PET in such a population, because in all these cases that were requested for or were asked if Alzheimer's disease is a potential diagnosis, you can see that the split is around 50-50 for positive and negative cases. So you can also rule out in a lot of the cases the Alzheimer's pathophysiology. But the most important message of this slide is you will only find only few discrepant cases with a positive visual read and negative centiloids, or with a negative visual read and positive centiloids. So in principle, this quantification can, even if you are not that experienced in amyloid PET reading, you can gain a very strong accuracy on the interpretation of such scans. And first, I will show you some clear clinical examples. So here in this case, very easy to see that all the amyloid goes out to the edge of the cortex in a mild cognitive impaired 62-year-old female. Also, the CSF A-beta ratio was here rather clear. Yeah? So now considering our data where we have established these two cutoffs, so here may the CSF would have been enough for a first diagnosis. But of course, if you want to treat a patient now with anti-amyloid treatment, it is of course important to still get the centiloid values to have a baseline before the treatment. But a very clear case. And on the opposite, here a very clear negative case, here with a mix of subjective memory impairment. Also in one rating it was MCI, very young. So then also following the proper reduce criteria for such a young person, amyloid PET was considered. Because the CSF was negative, but here the amyloid PET clearly confirmed the negativity, so no amyloid in the brain of this patient, and amyloid and Alzheimer's pathophysiology ruled out. So I think also clear clinical value, and here in this case high congruency between the visual read and the quantification. Then if you look here at the toolbox of the cPET software, you can also see how this then in the end works and provides you then clear positive images of an amyloid PET scan, in this case flutemetamol as a tracer, and you get here indicated by the arrow a centiloid value of 94. Here moderate dementia, also a young case, 65 years female, already cognitively declined to an MMSE of 22. And yeah, the amyloid PET can, with the quantification, provide you a clear answer that Alzheimer's disease is the underlying pathophysiology in that case. And also now with the software tool, one clear negative example. Subjective memory impairment, 79-year-old female. The A-beta ratio was also quite above 7.1, so also negative. MMSE was still 30, and you can see that here the quantification also nicely reflects that what you in this case can clearly see visually. So for these cases, of course, yeah, you don't need the magic of a quantitative tool because you could also read it visually, but there are different cases, and we will come to those soon. But just wanted to show you one example where I was personally a little bit surprised on the high centiloid value. So here's 78.7. And if you look at the scan, so they are not all regions that clearly positive. So you can see that in the frontal lobe, so you can assume that the scan shows positivity until the surface of the cortex, but for example, in the temporal lobe, it is clearly negative. So you can also, and I think these are the cases where unexperienced readers sometimes have difficulties. And you can see that even in those cases, you sometimes get real clear centiloid values that show you that the case is very clearly amyloid positive, although the visual read for an unexperienced reader can be also difficult. Here, a mild to moderate dementia case, 68 years old, male. And I think this is nice because it's a borderline case where you also get additive value through quantification. This is exactly in this borderline range between 5.5 and 7.1 for the CSF A beta ratio. And you can see that here the centiloid was 46. So although the scan is not looking completely positive at all sites where you can find amyloid, the centiloids are positive, and the case then also developed the dementia further and was diagnosed as an Alzheimer's disease case in the end. Here one case where you also have an additive value of the quantification. So here you see there was a little bit of a movement in the scan. So it's sometimes a little bit hard to spot here the pattern if it's going to the surface or if it's still a white matter gray matter contrast. And I think here as well these centiloid values can help you in the end, because here you see that it's still so a mild elevation of amyloid that you get reflected then by the quantification, and where you in the whole picture of the case can then assume that amyloid pathology is at least beginning in this individual person. Here we have a case that has mild cognitive impairment, but also gait disturbance. And here, of course, the question is it Alzheimer's disease or is it Parkinsonian syndrome, maybe atypical Parkinsonian syndrome? And yeah, so what to do with that case? Of course, we also did CSF before. Here again, an intermediate range. MMSE was 26. And again, we found a borderline value here for the centiloids. And yeah, of course, this helps you at least to judge that the case is not completely negative. So you cannot rule out Alzheimer's disease pathophysiology, but that you should evaluate the case then even further. And I think this is also something that brings us then in the university hospital setting to the next stage of evaluation. So using this centiloid quantification, we can judge these borderline cases with a centiloid value that is not completely positive or completely negative, as you can see here in this intermediate range. And I think that is also then exactly the population that can profit then from an additional tau PET scan. Because what you can see is that, of course, the tau PET SUVR is also positively correlating with the centiloid values. But it's extremely important, of course, here in this intermediate range. If you find a positive tau PET scan, you can, of course, be then sure that it's Alzheimer's disease, and maybe also a case that already begins to spread with the tau rather early in the buildup of amyloid. And if the tau PET is negative, in principle, especially if the case has also some cognitive impairment, then Alzheimer's disease pathophysiology is probably not the driver of this phenotype. And I will show you some examples for that. So again, we have a case with mild cognitive impairment, 75 years old, and with a beta ratio of 4, MMSE of 26, and a centiloid value that is in the borderline range, so 28.8. Again, if you compare here the visual read of the scan, yeah, so I think an unexperienced reader would really have hard times to judge if there is amyloid here in the frontal lobe or not. And I think therefore here already the quantification can help you. And if you do then a tau PET in such a case afterwards, you are able to judge that there is already beginning tau deposition, tau accumulation in the mesial temporal lobe, also temporal lateral, and in a little bit in the frontal and parietal lobe. So you need to consider that this SUVR is really harsh. So it's a scale from 1 to 2. So there you can even spot very tiny tau accumulation. But still, this pattern is very clear for a tau aggregation in Alzheimer's disease. So in the combination of the amyloid quantification, even if a visually uncertain amyloid PET scan, then in combination with the tau PET, you can resolve the question if this is really Alzheimer's disease pathophysiology or not. And a similar case here, mild cognitive impairment, 76 years old, also already cognitively impaired with an MMSE of 25. And here a ratio that was below the positivity threshold, so clear positive CSF. And the centiloids were at 34. Again, similar picture, you have some incidence that there could be amyloid in the frontal lobe in the visual read, but you are not that sure, like the temporal lobe is completely clean. Yeah, so what to do with this case? And I think again, here this combination of amyloid PET quantification and tau PET can help because yeah, you can nicely see that this case, even with this very harsh SUVR threshold, does not show any tau signal. So of course, now you need to think what is about the diagnosis and what to do with this patient. And I think now in the light of anti-amyloid treatments, we will frequently ask then in such cases the question, is this a case that we would treat even if the amyloid PET is only so faintly positive, but the ratio is positive? And yeah, I think in this case, the probability that really there occurs a larger tau spread in the very near future is very low. So these are May cases that will not really profit because this MMSE of 25 is likely not driven by Alzheimer's disease pathophysiology, but likely by something else. So in this case, the tau PET in combination with the amyloid PET quantification can help you then also for treatment decisions in yeah, already now or in the near future, depending on where you are located. So if we summarize this clinical experience that we gained with quantitative PET, I think the first key message, and this is really what we took also home on ourselves and what we have not expected so strong, is that the quantitative PET is really reliable if you compare it against an expert visual read that has been done by a 4-eye principal in a very routine center as we are. We have a good correlation with the CSF. Although here, of course, we need to see that the CSF and the amyloid PET show us different things. The one is the amyloid production, the other, like in the CSF, and in the visual read, we do really see the fibrillar amyloid plaques. So these are different components of the amyloid pathophysiology. But we can, of course, also use these informations together to see on which side or on which stage the patient is currently in the amyloid buildup. In my opinion, the quantification for amyloid PET has especially the additive value in the borderline cases. So these are the cases where we are not that clear in judging them amyloid positive or negative. So as you have seen from these centiloid values that we got, so we would have rated several of them even negative with the data-driven threshold of 35. But still, it is of course the question: is it an early Alzheimer's case that is just starting with the amyloid buildup and may even has some tau spread? And I think for judging if it's worth to follow up the case with another PET scan and to go deeper, I think this is a very valuable tool, because if a case, for example, has zero centiloids, you can leave it as it is and you can rule out Alzheimer's disease. But if you are in this borderline setting, then okay, this is a case where you should potentially put some more effort in. And yeah, I think that is what now is popping up, and that what also drives our excitement on these quantitative tools is that we have now anti-amyloid treatments available. They are may not as effective as some people would like to have them. However, if you compare these effects with an oncology setting, I think oncologists would really be happy to have such tools and such effect sizes of hazard ratios in place. So therefore, I think this quantitative amyloid PET will also be very relevant for treatment decisions. And I think also in cases that have only low amyloid, although they are positive, it will hopefully also guide us towards good decisions, because what we should consider is co-pathology. And I think cases that have already cognitive impairment but very low amyloid, these are made and also the cases where you should go for more clarification in terms of co-pathology. So yeah, with this, I'm very happy to answer, of course, any of your questions in the chat. And yeah, hope you can also share our excitement on quantitative amyloid PET imaging.
Great, perfect. Thank you very much, Professor Brendel. I will take over the screen quickly here to open up the Q&A session. So first of all, again, thank you for your great presentation. Very interesting. And we still have a couple of minutes for some questions. So I have some questions here where I'm going to pick and choose. So you nicely presented on the clinical usefulness of cPET for amyloid PET. But can you maybe please share your thoughts on FDG PET as well?
Yeah. So FDG PET is of course still an important tool, and yeah, we should not forget that in Munich we are in a very specialized center with the availability of a lot of new tracers, including tau PET and amyloid PET. But as also highlighted in the European recommendations, FDG PET is still a tool that can provide you a large clinical value if you do differential diagnosis in a patient that has dementia or movement disorder. And therefore, I think a tool as cPET is very elegant for FDG PET, because this is something that stratifies your case. Yeah? So you don't need just to rely on the simple visual recognition of a pattern, but you get in principle an analysis of the whole scan in its total, and also then in consideration of a database. And I think there are not only cPET showed this, but also a lot of studies, including the State Viewer by David Jones and colleagues, that this quantitative tools that analyze an FDG PET are highly valuable. And I think what is very cool, of course, is, and this is also what we should not forget in the community, cPET is a CE marketed tool and available also commercially. So I think this is also something that needs to be done, and that will help the community to foster the use of these PET tracers for dementia and movement disorders a lot.
Perfect. Very good point. Thank you. So maybe so we have 2 more minutes. Maybe one more question is, so you mentioned the importance of using amyloid PET quantification, so including centiloids, in addition to CSF. But before starting actually new Alzheimer's therapy, can you maybe elaborate on that a bit more, and maybe also comment on the role of centiloid quantification for therapy monitoring?
Yeah. Yeah, I think this is a very important question, and I think what we have learned clearly also from the phase 3 trials is that CSF monitoring is not really working. So we cannot judge if we are already successful with the therapy and if we removed all amyloid from the brain, but this can be done as shown in the donanemab trial by the centiloid quantification, and therefore. I think this can even be cost effective. So if you do an amyloid PET scan then after 12 months, and if you can save 6 months of therapy, then this is already a very clearly overcoming the cost of the amyloid PET. Even if you only find 30-40% of cases that are amyloid negative already, you will even go on the positive cost side. So I think that is a very clear and very useful tool to also even save money in economy systems.
Thank you very much. So to be respectful of time, so we are about at the end of our webinar session, but we have still some questions which we're going to ask, but we're going to gather them in a document, going to send them out to our speakers, collect the answers, and going to send it to the audience. So for everyone who asks a question, these are not going to be forget, but you will get them in a separate document. With that said, so thank you again, Professor Brendel, for your great presentation and spending the time with us. Also, I would like to thank the previous speakers again for the last previous sessions and everyone who actually attended our webinar series. With that said, we are going to wrap up our webinar series, and we hope everyone enjoyed it. And we are very much looking forward to get in touch with everyone again. So all the best and goodbye.